Chapter 14 Gastroenterology. Features of gastrointestinal disorders in children are vomiting, abdominal pain, and diarrhea are common and usually transient. Serious causes are uncommon but important to identify. Worldwide, gastroenteritis is responsible for 530,000 deaths per year, one of the most common causes of death in children under 5 years of age. The number of children and adolescents developing an inflammatory bowel disease is increasing. In contrast to adults, bowel cancer is extremely rare. Vomiting. Possetting and regurgitation are terms used to describe the non-forceful return of milk, but differ in degree. Possetting describes the small amounts of milk that often accompany the return of swallowed air, wind, whereas regurgitation describes larger, more frequent losses. Possetting occurs in nearly all babies from time to time, whereas regurgitation may indicate the presence of more significant gastroesophageal reflux. Vomiting is the forceful ejection of gastric contents. It is a common problem in infancy and childhood. It is usually benign and is often caused by feeding disorders or mild gastroesophageal reflux or gastroenteritis. Potentially serious disorders need to be excluded if the vomiting is bilious or prolonged, or if the child is systemically unwell or has faltering growth. In infants, vomiting may be associated with infection outside the gastrointestinal tract, especially in the urinary tract and central nervous system. In intestinal obstruction, the more proximal the obstruction, the more prominent the vomiting, and the sooner it becomes bowel stained, unless the obstruction is proximal to the ampulla or vata. Intestinal obstruction is associated with abdominal distension, more marked in distal obstruction. Red flag clinical features suggesting significant organic pathology are listed in box 14.1. Box 14.1 Red flag clinical features in the vomiting child. Bowel stain vomit suggesting intestinal obstruction. Hematemesis suggesting esophagitis, peptic ulceration, oral or nasal bleeding, and esophageal variceal bleeding. Projectile vomiting in the first few weeks of life, suggesting pyloric stenosis. Vomiting at the end of paroxysmal coughing, suggesting whooping cough, pertussis. Abdominal tenderness or abdominal pain or movement, suggesting surgical abdomen. Abdominal distension, suggesting intestinal obstruction, including strangulated inguinal hernia. Hepatosplenomegaly, suggesting chronic liver disease, inborn error of metabolism. Blood in the stool, suggesting intussusception, bacterial gastroenteritis. Severe dehydration or shock, suggesting severe gastroenteritis, systemic infection, for example, urinary tract infection or meningitis, or diabetic ketoacidosis. Bulging fontanelle or seizures, suggesting raised intracranial pressure. Faltering growth, suggesting gastroesophageal reflux disease, celiac disease, and other chronic gastrointestinal conditions. Summary of vomiting in infants. A common chronic cause is gastroesophageal reflux. Feed volumes should be calculated as overfeeding is common in bottle-fed infants. If transient with other symptoms, for example fever, diarrhea, or runny nose and cough, most likely to be gastroenteritis or respiratory tract infection, but consider urine infection, sepsis, or meningitis. If projectile at 2 to 8 weeks of age, exclude pyloric stenosis. If bowel stained, potential emergency, exclude intestinal obstruction, especially intussusception, malrotation, and a strangulated hernia. Assess for dehydration and shock. Gastroesophageal reflux. Gastroesophageal reflux is the involuntary passage of gastric contents into the esophagus. It is extremely common in infancy. It is caused by inappropriate relaxation of the lower esophageal sphincter as a result of functional immaturity. A predominantly fluid diet, a mainly horizontal posture, and a short intra-abdominal length of esophagus all contribute. While common in the first year of life, nearly all symptomatic reflux resolves spontaneously by 12 months of age. This is probably due to a combination of maturation of the lower esophageal sphincter, assumption of an upright posture, and more solids in the diet. Most infants with gastroesophageal reflux have recurrent regurgitation or vomiting, but are putting on weight normally and are otherwise well, although the mess, smell, and frequent changes of clothes. 5% of those affected have 6 or more episodes each day is frustrating for parents and carers. Gastroesophageal reflux is usually a benign, self-limited condition, but when it becomes a significant problem, it becomes gastroesophageal reflux disease and needs treatment. Gastroesophageal reflux disease is more common in children with cerebral palsy or other neurodevelopmental disorders, preterm infants, especially in those with bronchopulmonary dysplasia, following surgery for esophageal atresia or diaphragmatic hernia. Box 14.2 Complications of gastroesophageal reflux. In other words, gastroesophageal reflux disease. Faltering growth from severe vomiting, esophagitis, hematemesis, discomfort on feeding on or heartburn, iron deficiency anemia, recurrent pulmonary aspiration, recurrent pneumonia, cough or wheeze, apnea in preterm infants, dystonic neck posturing, also known as Sandifer syndrome, apparent life-threatening events. Investigations. Gastroesophageal reflux is usually diagnosed clinically and no investigations are required. However, they may be indicated if the history is atypical, complications are present, or there is failure to respond to treatment. Investigations include 24-hour esophageal pH monitoring to quantify the degree of acid reflux, 24-hour impedance monitoring, which is available in some centers, weakly acidic or non-acidic reflux, which may cause disease, is also measured. Endoscopy with esophageal biopsies to identify esophagitis and exclude other causes of vomiting. Contrast studies of the upper gastrointestinal tract may support the diagnosis, but are neither sensitive nor specific. They may be required in gastroesophageal disease to exclude underlying anatomical abnormalities in the esophagus, stomach, and duodenum, and to identify malrotation. Management. Uncomplicated gastroesophageal reflux has an excellent prognosis and can be managed by parental reassurance, adding inert thickening agent to feeds, for example, Carabel, and smaller, more frequent feeds. Significant gastroesophageal reflux disease is managed with acid suppression with either hydrogen receptors and antagonists, for example, ranitidine, or proton pump inhibitors, for example, meprazole. These drugs reduce the volume of gastric contents and treat acid-related esophagitis. The evidence for the use of drugs that enhance gastric emptying, for example domperidone, is poor, and as they are associated with significant side effects, their use should be discouraged. If the child fails to respond to these measures, other diagnoses such as cow's milk protein allergy should be considered and further investigations performed. Surgical management is reserved for children with complications unresponsive to intensive medical treatment or esophageal stricture. A nascent fundoplication, in which the fundus of the stomach is wrapped around the intra-abdominal esophagus, is performed either as an abdominal or laparoscopic procedure. Summary of gastroesophageal reflux. It occurs in otherwise normal infants, but risk is increased in the infant if the infant has neuromuscular problems or has had surgery to the esophagus or diaphragm. It is treated if troublesome with feed thickening medication, and rarely fundoplication. Investigations are performed if diagnosis is unclear or complications occur. Gastroesophageal reflux disease. Pyloric stenosis. In pyloric stenosis, there is hypertrophy of the pyloric muscle causing gastric outlet obstruction. It presents at 2 to 8 weeks of age, irrespective of gestational age. It is more common in boys, a ratio of 4 to 1. particularly firstborn, and there may be a family history, especially on the maternal side. Clinical features are vomiting, which increases in frequency and forcefulness over time, ultimately becoming projectile, hunger after vomiting until dehydration leads to loss of interest in feeding, weight loss if presentation is delayed, a hypochloremic metabolic acidosis with a low plasma sodium and potassium occurs as a result of vomiting stomach contents. Diagnosis: unless immediate fluid resuscitation is required, a test feed is performed. The baby is given a milk feed, which will calm the hungry infant, allowing examination. Gastric peristalsis may be seen as a wave moving from left to right across the abdomen. The pyloric mass, which feels like an olive, is usually palpable in the right upper quadrant. If the stomach is over-distended with air, it will need to be emptied by a nasogastric tube to allow palpation. Ultrasonic examination may be helpful to confirm the diagnosis prior to surgery. Management: the initial priority is to correct any fluid and electrolyte disturbance with intravenous fluids. Once hydration and acid base and electrolytes are normal, definitive treatment by pyloromyotomy can be performed. This involves division of the hypertrophic muscle down to but not including the mucosa. The operation can be performed either as an open procedure via periumbilical incision or laparoscopically. Postoperatively, the child can usually be fed within 6 hours and discharged within 2 days of surgery. Summary of pyloric stenosis. Pyloric stenosis is more common in boys and in those with a family history. Signs are visible: gastric peristalsis, palpable abdominal mass on test feed, and possible dehydration. Associated with hyponatremia, hypokalemia, and hypochloremic alkalosis. Diagnosis may be confirmed by ultrasound. Treated by surgery after rehydration and correction of electrolyte imbalance. Crying. The time healthy babies cry for is highly variable. In most, it represents the baby's response to hunger and discomfort. Reassurance and advice on appropriate feeding will usually suffice. Some babies cry for prolonged periods in spite of feeding and comforting, and this is distressing for all concerned. It can engender a feeling of anxiety, helplessness, and depression in parents and carers, particularly if they are inexperienced or poorly supported. It has also been suggested that the emotional climate within a home may be transmitted to a baby, and that in some instances, tense, anxious, or irritable caregivers are more likely to have fretful babies. The complaint that a baby is always crying may also be a pointer to potential or actual non-accidental injury. A cause for the crying is identified in a minority of infants. If of sudden onset, it may be due to a urinary tract, middle ear, or meningeal infection, pain from an unrecognized fracture, esophagitis, or torsion of the testis. Severe nappy rash and constipation may produce a miserable crying infant. Preterm infants who have spent several weeks in hospital can be difficult to settle, as can infants with a chronic neurological disorder, for example, cerebral palsy. On the basis of countless reports of parents, eruption of teeth is painful in some infants. However, teething does not cause vomiting, diarrhea, high fever, or seizures. Acknowledging that troublesome crying is extremely distressing is part of the management. Reducing overstimulation from jigging and winding and encouraging a quiet environment and holding the baby close until the crying stops appears to help many babies. Parental support through follow up may by health professionals is helpful. Infant colic. The term colic is used to describe a common symptom complex that occurs during the first few months of life. Paroxysmal, inconsolable crying or screaming, often accompanied by drawing up of the knees and passage of excessive flatus, takes place several times a day. There is no firm evidence that the cause is gastrointestinal, but this is often suspected. The condition occurs in up to 40% of babies. It typically occurs in the first few weeks of life and resolves gradually from 3 to 12 months of age. The condition is benign but is very frustrating and worrying for parents and may precipitate non accidental injury in infants already at risk. Support and reassurance should be given. Gripe water is often recommended but is of unproven benefit. If severe and persistent, it may be due to a cow's milk protein allergy, and an empirical 2-week trial of a protein hydrolysate formula, cow's milk protein free, may be considered and continued if symptoms improve. If they do not, then a trial of gastroesophageal reflux treatment may be considered. Acute abdominal pain. Assessment of the child with acute abdominal pain requires considerable skill. The differential diagnosis of acute abdominal pain in children is extremely wide, encompassing non-specific abdominal pain, surgical causes, and medical conditions. In nearly half of the children admitted to hospital, the pain resolves undiagnosed. In young children, it's essential not to delay the diagnosis and treatment of acute appendicitis, as progression to perforation can be rapid. It is easy to belittle the clinical signs of abdominal tenderness in young children. Of the surgical causes, appendicitis is by far the most common. The testis, hernial orifices, and hip joints must always be checked. It is noteworthy that lower lobe pneumonia may cause pain referred to the abdomen. Primary peritonitis is seen in patients with ascites from nephrotic syndrome or liver disease. Diabetic ketoacidosis may cause severe abdominal pain. Urinary tract infection, including acute pyelonephritis, is a relatively uncommon cause of acute abdominal pain, but must not be missed. It is important to test a urine sample in order to identify not only diabetes mellitus but also conditions affecting the liver and urinary tract. Pancreatitis may present with an acute abdominal pain and serum amylase should be checked. Acute appendicitis. Acute appendicitis is the most common cause of abdominal pain in children requiring surgical intervention. Although it may occur at any age, it is very uncommon in children under 3 years of age. The clinical features of acute uncomplicated appendicitis are: the symptoms include anorexia, vomiting, abdominal pain, initially central and colicky, appendicular midgut colic, but then localizing to the right iliac fossa from localized peritoneal inflammation. Signs include fever, abdominal pain aggravated by movement, for example, on walking, coughing, jumping, bumps on the road during a car journey. Persistent tenderness with guarding in the right iliac fossa, McBurney's point. However, with a retrocecal appendix, localized guarding may be absent, and in a pelvic appendix, there may be a few abdominal signs. In preschool children, the diagnosis is more difficult, particularly early in the disease. Fecal lifts are more common and can be seen on a plain abdominal X-ray. Perforation may be rapid, as the omentum is less well developed and fails to surround the appendix, and signs are easy to underestimate at this age. Appendicitis is a progressive condition, and so repeated observation and clinical review every few hours are key to making the correct diagnosis, avoiding a delay on one hand and unnecessary laparotomy on the other. The laboratory investigation or imaging is consistently helpful in making the diagnosis. Oh, no laboratory investigation or imaging is consistently helpful in making the diagnosis. A neutrophilia is not always present on a full blood count, while white blood cells or organisms in the urine are not uncommon in appendicitis, as the inflamed appendix may be adjacent to the ureter or bladder. Although ultrasound is no substitute for regular clinical review, it may support the clinical diagnosis. thickened, non-compressible appendix with increased blood flow, and demonstrate associated complications such as an abscess, perforation, or an appendix mass, and may exclude other pathology causing the symptoms. In some centers, laparoscopy is available to see whether or not the appendix is inflamed. Appendicectomy is straightforward in uncomplicated appendicitis. Complicated appendicitis includes the presence of an appendix mass, an abscess, or perforation. If there is generalized scarring consistent with perforation, fluid resuscitation and intravenous antibiotics are given prior to laparotomy. If there is a palpable mass in the right iliac fossa and there are no signs of generalized peritonitis, it may be reasonable to elect for a conservative management with intravenous antibiotics and appendicectomy being performed after several weeks. If symptoms progress, laparotomy is indicated. Nonspecific abdominal pain and mesenteric adenitis. Nonspecific abdominal pain is abdominal pain which resolves in 24 to 48 hours. The pain is less severe than in appendicitis, and tenderness in the right iliac fossa is variable. It is often accompanied by an upper respiratory tract infection with cervical lymphadenopathy. In some of these children, the abdominal signs do not resolve and an appendicectomy is performed. Mesenteric adenitis is often diagnosed in those children in whom large mesenteric nodes are seen at laparoscopy and whose appendix is normal, but there are doubts whether this condition truly exists as a diagnostic entity. Intussusception. Intussusception describes the invagination of proximal bowel into a distal segment. It most commonly involves ileum passing into the cecum through the ileocecal valve. Intussusception is the most common cause of intestinal obstruction in infants after the neonatal period. Although it may occur at any age, the peak age of presentation is 3 months to 2 years of age. The most serious complication is stretching and constriction of the mesentery, resulting in venous obstruction, causing engorgement and bleeding from bowel mucosa, fluid loss, and subsequently bowel perforation, peritonitis, and gut necrosis. Prompt diagnosis, immediate fluid resuscitation, and urgent reduction of the intussusception are essential to avoid complications. Presentation is typically with paroxysmal severe colicky pain with pallor during episodes of pain, and the child becomes pale, especially around the mouth, and draws up the legs. There is recovery between the painful episodes, but subsequently the child may become increasingly lethargic, may refuse feeds, may vomit, which may become bowel stain depending on the site of the intussusception. A sausage-shaped mass, often palpable in the abdomen. Passage of a characteristic red currant jelly stool comprising blood-stained mucus. This is a characteristic sign but tends to occur later in the illness and may be first seen after a rectal examination. Abdominal distension and shock. Usually, no underlying intestinal cause for the intussusception is found, although there is some evidence that viral infection leading to enlargement of Peyer's patches may form the lead point of the intussusception. An identifiable lead point, such as Meckel's diverticulum or polyp, is more likely to be present in children over 2 years of age. Intravenous fluid resuscitation is likely to be required immediately as there is often pooling of fluid in the gut, which may lead to hypovolemic shock. An X-ray of the abdomen may show a distended small bowel and absence of gas in the distal colon or rectum. Sometimes the outline of the intussusception itself can be visualized. Abdominal ultrasound is helpful both to confirm the diagnosis, the so-called target or donut sign, and to check response to treatment. Unless there are signs of peritonitis, reduction of the intussusception by rectal air insufflation is usually attempted by a radiologist. This procedure should only be carried out once the child has been resuscitated and is under the supervision of a pediatric surgeon in case the procedure is unsuccessful or bowel perforation occurs. The success rate of the procedure is about 75%. The remaining 25 require operative reduction. Recurrence of the intussusception occurs in less than 5% but is more frequent after hydrostatic reduction. Summary of intussusception usually occurs between 3 months and 2 years of age. Clinical features are paroxysmal, colicky pain with pallor, abdominal mass, and recurrent jelly stool. Shock is an important complication and requires urgent treatment. Reduction is attempted by rectal air insufflation unless peritonitis is present. Surgery is required if reduction with air is unsuccessful or for peritonitis. Meckel's diverticulum. Around 2% of individuals have an ileal remnant of the vitelo-intestinal duct, a Meckel diverticulum which contains ectopic gastric mucosa or pancreatic tissue. Most are asymptomatic, but they may present with severe rectal bleeding, which is classically neither bright red nor true melena. There is usually an acute reduction in hemoglobin. Other forms of presentation include intussusception, volvulus twisting of the bowel, or diverticulitis, when inflammation of the diverticulum mimics appendicitis. A technetium scan will demonstrate increased uptake by ectopic gastric mucosa in 70% of cases. Treatment is by surgical resection. Summary of Meckel's diverticulum occurs in 2% of individuals, generally asymptomatic, but may present with bleeding, which may be life-threatening or intussusception or volvulus. Treatment is by surgical resection. Malrotation. During rotation of the small bowel in fetal life, if the mesentery is not fixed at the duodenojejunal flexure or if the ileocecal region or in the ileocecal region, its base is shorter than normal and is predisposed to volvulus. Lead bands are peritoneal bands that may cross the duodenum, often anteriorly. There are two presentations: obstruction or obstruction with a compromised blood supply. Obstruction with bilious vomiting is the usual presentation in the first few days of life but can be seen at a later age. Any child with dark green vomiting needs an urgent upper gastrointestinal contrast study to assess intestinal rotation. Unless signs of vascular compromise are present, when an urgent laparotomy is needed, this is a surgical emergency as when a volvulus occurs, the superior mesenteric arterial blood supply to the small intestine and proximal large intestine is compromised and unless it is corrected, will lead to infarction of these areas. At operation, the volvulus is untwisted, the duodenum mobilized, and the bowel placed in the non-rotated position, with the duodenojejunal flexure on the right and the cecum and appendix on the left. The malrotation is not corrected, but the mesentery broadened. The appendix is generally removed to avoid diagnostic confusion should the child subsequently have symptoms suggestive of appendicitis. Summary of malrotation. Uncommon but important to diagnose. Usually presents in the first 1 to 3 days of life with intestinal obstruction from lead bands obstructing the duodenum or volvulus. May present at any age with volvulus causing obstruction and ischemic bowel. Clinical features are bilious vomiting, abdominal pain and tenderness from peritonitis or ischemic bowel. An urgent upper gastrointestinal contrast study is indicated if there is bilious vomiting. Treatment is urgent surgical correction. Recurrent abdominal pain. Recurrent abdominal pain is a common childhood problem. It is often defined as pain sufficient to interrupt normal activities and lasts for at least 3 months. It occurs in about 10% of school-age children and organic cause is identified in less than 10% of cases. The pain is characteristically periumbilical, and the children are otherwise entirely well. Constipation is a frequent cause of recurrent abdominal pain and must be excluded. The widely held belief that they have psychogenic pain is without foundation, with a number of studies having failed to show a difference between such children and their families and controls. In some children, it may, however, be a manifestation of stress, or it may become part of a vicious cycle of anxiety with escalating pain leading to family distress and demands for increasingly invasive investigations. There is evidence that anxiety may lead to altered bowel motility, which may be perceived by the child as pain. It is increasingly recognized that many will have distinct symptom constellation resulting from functional abnormalities of gut motility, irritable bowel syndrome most common, constipation, and less commonly celiac disease, abdominal migraine, and functional dyspepsia. Management. The aim is to identify any serious cause without subjecting the child to unnecessary investigation while providing reassurance to the child and parents. To do this, a full history and thorough examination is required, which includes inspection of the perineum for anal fissures, the child's growth for anal fissures. The child's growth should be checked. A urine microscopy and culture is mandatory as urinary tract infections may cause pain in the absence of other symptoms or signs. An abdominal ultrasound is particularly helpful in excluding gallstones and pelvic ureteric junction obstruction. Although there are many potential organic causes, most are rare. Celiac antibodies and thyroid function tests should be checked, but further investigations should be performed only if clinically indicated. With irritable bowel syndrome and functional dyspepsia, it can be helpful to explain to both the child and parents that sometimes the insides of the intestine become so sensitive that some children can feel the food going around the bends. It is also necessary to make a distinction between serious and dangerous. These disorders can be serious if, for example, they lead to substantial loss of schooling, but they are not dangerous. The long term prognosis is that about half of affected children rapidly become free of symptoms. In one quarter, the symptoms take some months to resolve. In one quarter, symptoms continue to return in adulthood as migraine, irritable bowel syndrome, or functional dyspepsia. Abdominal migraine. Abdominal migraine is often associated with abdominal pain in addition to headaches, and in some children, the abdominal pain predominates. The attacks of abdominal pain are midline associated with vomiting and facial pallor. There is usually a personal or family history of migraine. The history is characteristic with long periods, often weeks, of no symptoms, and then a shorter period, 12 to 48 hours, of non-specific abdominal pain and pallor, with or without vomiting. Treatment with anti-migraine medication may be of benefit if the problem causes school absence. Irritable bowel syndrome. This disorder, also common in adults, is associated with altered gastrointestinal motility and an abnormal sensation of intra-abdominal events. Symptoms may be precipitated by gastrointestinal infection. Studies of pressure changes within the small intestine of children with irritable bowel syndrome suggest that abnormally forceful contractions occur. It has also been shown that affected adults experience pain on inflation of balloons in the intestine and substantially lower volumes than do controls. There is therefore an interplay between these two factors, both of which are modulated by psychosocial factors such as stress and anxiety. There is often a positive family history and characteristic set of symptoms, although not all patients experience every symptom. The symptoms include non-specific abdominal pain, often periumbilical, may be worse before or relieved by defecation, explosive loose or mucousy stools, bloating, feeling of incomplete defecation, constipation often alternating with normal or loose stools. Some children and adults with irritable bowel symptoms have celiac disease, which is why celiac antibody serology must be checked. Peptic ulceration, gastritis, and functional dyspepsia. The greater use of endoscopy in children and the identification of the gram-negative organism Helicobacter pylori in association with enterogastritis have focused attention on it as a potential cause of abdominal pain in children. In adults, and probably in children, there is substantial evidence that H. pylori is a strong predisposing factor to duodenal ulcers. Duodenal ulcers are uncommon in children but should be considered in those with epigastric pain, particularly if it wakes them at night, if the pain radiates through to the back, or when there is a history of peptic ulceration in a first degree relative. H. pylori causes a nodular enterogastritis, which may be associated with abdominal pain and nausea. It is usually identified in gastric enterobiopsies. The organism produces urease, which forms the basis for a laboratory test on biopsies and the carbon 13 breath test, following the administration of carbon 13 labeled urea by mouth. Stool antigen or for H. pylori may be positive in infected children. Serological tests are less reliable in young children but may be helpful in older children. Children in whom peptic ulceration is suspected should be treated with proton pump inhibitors, for example, omeprazole, and if investigations suggest they have an H. pylori infection, eradication therapy should be given, amoxicillin and metronidazole or clarithromycin. Those who fail to respond to treatment or whose symptoms recur on stopping treatment should have an upper gastrointestinal endoscopy, and if this is normal, functional dyspepsia is diagnosed. Functional dyspepsia is probably a variant of irritable bowel syndrome. As well as having symptoms of peptic ulceration, children with functional dyspepsia have rather more nonspecific symptoms, including early satiety, bloating, and postprandial vomiting, and maybe delayed gastric emptying as a result of gastric dysmotility. Treatment is difficult, but some children respond to a hypoallergenic diet. Eosinophilic esophagitis. Eosinophilic esophagitis is an inflammatory condition affecting the esophagus caused by activation of eosinophils within the mucosa and submucosa. It can present with vomiting, discomfort, or swallowing or bolus dysphagia when food sticks in the upper chest. It is probably an allergic phenomenon, although the precise pathophysiology is unclear. It is more common in children with other features of atopy, for example, asthma, eczema, and hay fever. Diagnosis is by endoscopy where microscopically linear furrows and trachealization of the esophagus may be seen, and microscopically eosinophilic infiltration is identified. Treatment is with swallowed corticosteroids in the form of fluticasone or viscous budesonide. Exclusion diets may be of a benefit in young children. Gastroenteritis. In developing countries, gastroenteritis remains a major cause of child mortality. In developed countries, it is a cause of significant morbidity, particularly in younger children. In the UK, approximately 10% of children under 5 years of age annually present to health services with gastroenteritis, and it remains a common reason for hospital admission in young children. The most frequent cause of gastroenteritis in developed countries is rotavirus infection, which accounts for about 60% of cases in children under 2 years of age, particularly during the winter and early spring. An effective vaccine against rotavirus is available. It has not been adopted into the national immunization program in the UK but is given in many other countries. Other viruses, particularly adenovirus, norovirus, calicivirus, coronavirus, and astrovirus, may cause outbreaks. Bacterial causes are less common in developed countries but may be suggested by the presence of blood in the stools. Campylobacter jejuni infection, the most common of the bacterial infections is developed in developed countries, is most associated with severe abdominal pain. Shigella and some Salmonella produce a dysenteric type of infection with blood and pus in the stool, pain, and tenesmus. Shigella infection may be accompanied by high fever. Cholera and enterotoxigenic Escherichia coli infection are associated with profuse, rapidly dehydrating diarrhea. However, clinical features act as a poor guide to the pathogen. The third cause of gastroenteritis is protozoan parasite infections such as Giardia and Cryptosporidium. In gastroenteritis, there is a sudden change to loose or watery stools, often accompanied by vomiting. There may be a contact with a person with diarrhea and or vomiting or recent travel abroad. A number of disorders may masquerade as gastroenteritis. Box 14.3. And when in doubt, hospital referral is essential. Dehydration leading to shock is the most serious complication, and its prevention of correction is the main aim of treatment. The following children are at increased risk of dehydration: infants, particularly those under 6 months of age, or those born with low birth weight, if they have passed 6 or more diarrheal stools in the previous 24 hours, if they have vomited 3 or more times in the previous 24 hours, if they have been unable to tolerate or not been offered extra fluids, if they have malnutrition. Infants are at particular risk of dehydration because they have a greater surface area to weight ratio than older children, leading to greater insensible water loss. 300 ml per meter square per day, equivalent in infants to 15 to 17 ml per kg per day. They also have higher basal fluid requirements, 100 to 120 ml per kg per day, in other words, 10 to 12% of body weight, and immature renal tubular reabsorption. They also have a higher basal fluid requirements and immature renal tubular reabsorption. In addition, they are unable to obtain fluids for themselves when thirsty. Assessment. Clinical assessment of dehydration is important but difficult. The most accurate measure of dehydration is the degree of weight loss during the diarrheal illness. A recent weight measurement is useful but is often not available and may be misleading if the child had clothes on or the different measuring scales are not accurate. The history and examination are used to assess the degree of dehydration, as no clinically detectable dehydration, usually less than 5% of loss of body weight, clinical dehydration, usually 5 to 10% of loss of body weight, or shock, usually more than 10% loss of body weight. And shock must be identified without delay. Isonatremic and hyponatremic dehydration. In dehydration, there is a total body deficit of sodium and water. In most instances, the losses of sodium and water are proportional and plasma sodium remains within the normal range. Isonatremic dehydration. When children with diarrhea drink large quantities of water or other hypotonic solutions, there is a greater net loss of sodium than water, leading to a fall in plasma sodium, hyponatremic dehydration. This leads to a shift of water from extracellular to intracellular compartments. The increase in intracellular volume leads to an increase in the brain volume, which may result in seizures, whereas the marked extracellular depletion leads to a greater degree of shock per unit of water loss. This form of dehydration is more common in poorly nourished infants in developing countries. Hypernatremic dehydration. Infrequently, water loss exceeds the relative sodium loss and plasma sodium concentration increases. Hypernatremic dehydration. This usually results from high insensible water loss, high fever or hot, dry environment, or from profuse low sodium diarrhea. The extracellular fluid becomes hypertonic with respect to intracellular fluid, which leads to the shift of water into extracellular space from the intracellular compartment. Signs of extracellular fluid depletion are therefore less per unit of fluid loss, and depression of the fontanelle reduced tissue elasticity, and sunken eyes are less obvious. This makes this form of dehydration more difficult to recognize clinically, particularly in an obese infant. It is particularly dangerous it is a particularly dangerous form of dehydration as water is drawn out of the brain and cerebral shrinkage within a rigid skull may lead to jittery movements, increased muscle tone with hyperreflexia, altered consciousness, seizures, and multiple small cerebral hemorrhages. Transient hyperglycemia occurs in some patients with hypernatremic dehydration. It is self-correcting and does not require insulin. Investigation. Usually, no investigations are indicated. Stool culture is required if the child appears septic, if there is blood or mucus in the stools, or child is immunocompromised. It may be indicated following recent foreign travel if the diarrhea had not improved by day 7, or if the diagnosis is uncertain. Plasma electrolytes, urea, creatinine, and glucose should be checked if intravenous fluids are required or there are features suggestive of hypernatremia. If antibiotics are started, a blood culture should be taken. Management. This is shown in figure 14.10. Where clinical dehydration is not present, the aim is its prevention. If there is clinical dehydration, oral rehydration solution is the mainstay of therapy. It may also be used as an adjunct in this prevention. Intravenous fluids are only indicated for shock or deterioration or persistent vomiting. Hypernatremic dehydration. Hmm. The management of hypernatremic dehydration can be particularly difficult. Oral rehydration solution should be used to rehydrate hypernatremic children with clinical dehydration. If intravenous fluids are required, a rapid reduction in plasma sodium concentration and osmolality will lead to a shift of water into cerebral cells and may result in seizures and cerebral edema. The reduction in plasma sodium should therefore be slow. The fluid deficit should be replaced over at least 48 hours with 0.9% or 0.45% saline, and the plasma sodium measured regularly, aiming to reduce it at less than zero point 0.5 millimoles per liter per hour. Antidiarrheal drugs, for example, loperamide, Lometil, and antiemetics. There is no place for medications for the vomiting or diarrhea of gastroenteritis in children as they are ineffective, may prolong the excretion of bacteria in stools, can be associated with side effects, and unnecessary to cause. Focus attention away from oral rehydration. Antibiotics. Antibiotics are not routinely required to treat gastroenteritis, even if there is a bacterial cause. They are only indicated for suspected or confirmed sepsis, extraintestinal spread of bacterial infection, for Salmonella gastroenteritis if aged under 6 months, in malnourished or immunocompromised children, or for specific bacterial or protozoal infections. For example, Clostridium difficile associated with pseudomembranous colitis, cholera, shigellosis, giardiasis. Nutrition. In developing countries, multiple episodes of diarrhea are a major contributing factor to the development of malnutrition. Following diarrhea, nutritional intake should be increased. Diarrhea may be associated with zinc deficiency, and supplementation may be helpful in both acute diarrhea and as prophylaxis. In gastroenteritis, death is from dehydration. Its prevention and correction is the mainstay of treatment. Post-gastroenteritis syndrome. Infrequently, following an episode of gastroenteritis, the introduction of a normal diet results in a return of low watery diarrhea. In such cases, oral rehydration therapy should be restarted. Summary of gastroenteritis results in death from dehydration of hundreds of thousands of children worldwide every year. It's mostly viral, but it can be caused by Campylobacter, Shigella, and Salmonella, and other organisms. Infants are particularly susceptible to dehydration. Dehydration is assessed as no clinical dehydration, or shock according to symptoms and signs, but clinical assessment of severity is problematic. Oral rehydration solution is the mainstay of treatment and usually effective. Intravenous fluid is only required for shock or ongoing vomiting or clinical deterioration. Malabsorption. Disorders affecting the digestion or absorption of nutrients manifest as abnormal stools, poor weight gain, or faltering growth in most but not all cases, specific nutrient deficiencies either singly or in combination. In general, parents know when their children's stools have become abnormal. The true malabsorption stool is difficult to flush down the toilet and has an odor that pervades the whole house. In general, color is a poor guide to abnormality. Reliable dietetic assessment is important. It is inappropriate to investigate children for malabsorption as a cause of their faltering growth when dietary energy intake is demonstrably low and other symptoms are absent. Some disorders affecting the small intestine mucosa, intestinal mucosa, or pancreas, chronic pancreatic insufficiency, may lead to the malabsorption of many nutrients, pan malabsorption, whereas others are highly specific, for example, zinc malabsorption in acrodermatitis enteropathica. Celiac disease. Celiac disease is an enteropathy in which the gliadin fraction of gluten and other related prolamins in the wheat, barley, and rye provoke a damaging immunological response in the proximal small intestinal mucosa. As a result, the rate of migration of absorptive cells moving up the villi enterocytes from the crypts is massively increased, but is insufficient to compensate for increased cell loss from the villus tips. Villi become progressively shorter and then absent, leaving a flat mucosa. It is a relatively common disorder occurring in 1% of the population. The incidence of classical celiac disease diagnosed in childhood on the basis of characteristic clinical symptoms has been about 1 in 3,000 in Europe, including the UK. The age at presentation is partially influenced by the age of introduction of gluten into the diet. The classical presentation is a profound malabsorptive syndrome at 8 to 24 months of age after the introduction of wheat containing weaning foods. There is faltering growth, abdominal distension, and buttock wasting, abnormal stools, and general irritability. However, this classical form is no longer the most common presentation, and children are now more likely to present less acutely in later childhood. The clinical features of celiac disease can be highly variable and include mild, non-specific gastrointestinal symptoms, anemia, iron and/or folate deficiency, and growth faltering. Alternatively, it is identified on screening of children at increased risk, for example, with type 1 diabetes mellitus, autoimmune thyroid disease, or Down syndrome, and first degree relatives of individuals with known celiac disease. The introduction of highly sensitive and specific serological screening tests, anti-TTG, immunoglobulin A tissue transglutaminase antibodies, and EMA, endomysial antibodies, has provided evidence that celiac disease is much more common than previously thought, and as many as 1 in 100 UK school-aged children may be antibody positive, but a large proportion of these children will be asymptomatic. Diagnosis. Although the diagnosis is strongly suggested by positive serology, confirmation depends upon the demonstration of mucosal changes, increased intraepithelial lymphocytes, and a variable degree of villus atrophy and crypt hypertrophy. On small intestinal biopsy performed endoscopically followed by the resolution of symptoms and catch-up growth upon gluten withdrawal. Although there is no place for the empirical use of a gluten-free diet as a diagnostic test for celiac disease, strongly positive serological tests such as anti-TDG and EMA in the symptomatic individuals may make the need for biopsy confirmation unnecessary in a small proportion of children following assessment by a pediatric gastroenterologist. Management. All products containing wheat, Rye and barley are removed from the diet, and this results in resolution of symptoms. Supervision by a dietitian is essential. In children in whom the initial biopsy or the response to gluten withdrawal is doubtful, a gluten challenge may be required in later childhood to demonstrate continuing susceptibility of the small intestine mucosa to damage by gluten. The gluten-free diet should be adhered to for life. Non-adherence to the diet risks the development of micronutrient deficiency, especially osteopenia, and there is a small but definite increased risk of bowel malignancy, especially small bowel lymphoma. Summary of celiac disease. A gluten-sensitive enteropathy. Classical presentation is at 8 to 24 months of age with abnormal stools, faltering growth, abdominal distension, muscle wasting, and irritability, which is now rare. Other more subtle modes of presentation, for example, short stature, anemia, abdominal pain, and screening, for example, in children with diabetes mellitus, are now much more common. Diagnosis: positive serology, IgA tissue transglutaminase and endomycin antibodies. Flat mucosa and duodenal biopsy, usually but not always performed, and resolution of symptoms and catch-up growth upon gluten withdrawal. Treatment: gluten-free diet for life. Food allergy and intolerance. This is described in Chapter 16, Allergy. Other causes of nutrient malabsorption. These are summarized in Figure 14.13. Short bowel syndrome usually occurs when an infant or child has had a large surgical resection. This may be due to congenital atresia, necrotizing enterocolitis, malrotation with a volvulus, or traumatic event such as a road traffic accident. Depending on the length and type of residual bowel, ileum or jejunum, and presence of ileocecal valve, these children may develop malabsorption, diarrhea, and malnutrition. If severe, they may require supplemental parenteral nutrition for their intestinal failure. They are at risk from nutritional deficiencies, intestinal failure associated liver disease, and central line associated bloodstream infections, and need to be managed by specialist multidisciplinary teams. Chronic non-specific diarrhea. This condition, previously known as toddler diarrhea, is the most common cause of persistent loose stools. In preschool children, characteristically, the stools are of varying consistency, sometimes well formed, sometimes explosive and loose. The presence of undigested vegetables in the stools is common. Affected children are well and thriving. In a proportion of children with diarrhea, may result from undiagnosed celiac disease or excessive ingestion of fruit juice, especially apple juice. Occasionally, the cause is temporary cow's milk allergy following gastroenteritis, when a trial of cow's milk protein-free diet may be helpful. Once possible underlying causes have been excluded, in the majority of cases, the loose stools probably result from dysmotility in the gut, a form of irritable bowel syndrome, and fast transit diarrhea. It almost always improves with age. Summary of chronic diarrhea. In an infant with faltering growth, consider celiac disease and cow's milk protein allergy. Following bowel resection, cholestatic liver disease, or exocrine pancreatic dysfunction, consider malabsorption. In an otherwise well toddler with undigested vegetables in the stool, consider chronic non-specific diarrhea. Inflammatory bowel disease. The incidence of inflammatory bowel disease in children has increased markedly in the last 2 decades. The reason for this is unclear, but recent evidence suggests a complex interplay between genetics, gut microbiome, and mucosal immunity is responsible. A number of genes have been identified to give an increased risk, but this is often in association with increased risk of other autoimmune diseases that do not always coexist with an inflammatory bowel disease. Approximately a quarter of patients present in childhood or adolescence, and in contrast with the adult population, Crohn's disease is more common than ulcerative colitis. Crohn's disease can affect any part of the gastrointestinal tract from mouth to anus, whereas in ulcerative colitis, the inflammation is confined to the colon. Inflammatory bowel disease may cause poor general health, restrict growth, and have an adverse effect on psychological well being. Management requires a specialist multidisciplinary team. Crohn's disease. The clinical features of Crohn's disease are summarized in Figure 14.414. Lethargy and general ill health without gastrointestinal symptoms can be the presenting features, particularly in older children. There may be considerable delay in diagnosis as it may be mistaken for psychological problems. It may also mimic anorexia nervosa. The presence of raised inflammatory markers, platelet count, erythrocyte sedimentation rate, and C-reactive protein, iron deficiency anemia, and low serum albumin are helpful in both making a diagnosis and confirming a relapse. Crohn's disease is a transmural focal subacute or chronic inflammatory disease, most commonly affecting the distal ileum and proximal colon. Initially, there are areas of acutely inflamed thickened bowel. Subsequently, strictures of the bowel and fistula may develop between adjacent loops of bowel, between bowel and skin, or to other organs, for example, the vagina and bladder. Diagnosis is based on endoscopic and histological findings on biopsy, upper gastrointestinal endoscopy, ileocolonoscopy, and small bowel imaging are required. The histological hallmark is the presence of non-caseating epithelioid cell granulomata, although this is not identified in up to 30% at presentation. Small bowel imaging may reveal narrowing, fissuring, mucosal irregularities, and bowel wall thickening. Remission is induced with nutritional therapy when the normal diet is replaced by whole protein modular feeds polymeric diet for 6 to 8 weeks. This is effective in 75% of cases. Systemic steroids are required if ineffective. Relapse is common, and immunosuppressant medication azathioprine, mercaptopurine, or methotrexate is almost always required to maintain remission. Anti-tumor necrosis factor agents, infliximab or adalimumab, may be needed to when conventional treatments have failed. Long-term supplemental enteronutrition, often with overnight nasogastric or gastrostomy feeds, may be helpful in correcting growth failure. Surgery is necessary for complications of Crohn's disease, obstruction, fistula, abscess formation, or severe localized disease unresponsive to medical treatment, often manifesting as growth failure. In general, the long-term prognosis for Crohn's disease beginning in childhood is good, and most patients lead normal lives despite occasional relapsing disease. Growth failure and delayed puberty are features of Crohn's disease in children. Ulcerative colitis. Ulcerative colitis is a recurrent inflammatory and ulcerating disease involving the mucosa of the colon. Characteristically, the disease presents with rectal bleeding, diarrhea, and colicky pain. Weight loss and growth failure may occur, although this is less frequent than Crohn's disease. Extraintestinal complications include erythema nodosum and arthritis. The diagnosis is made on endoscopy, upper and ileocolonoscopy, and on the histological features after exclusion of infective causes of colitis. There is a confluent colitis extending from the rectum proximally for a variable length. In contrast to adults in whom the colitis is usually confined to the distal colon, 90% of children have pancolitis. Histology reveals mucosal inflammation, crypt damage, cryptitis, architectural distortion, abscess and crypt loss, and ulceration. Small bowel imaging is required to check that extracolonic inflammation suggestive of Crohn's disease is not present. In mild disease, aminosalicylates, for example mesalazine, are used for induction of maintenance and for induction and maintenance therapy. Disease confined to the rectum and sigmoid colon, rare in children, may be managed with topical steroids. More aggressive or extensive disease requires systemic steroids for acute exacerbations and immunomodulatory therapy, for example azathioprine alone to maintain remission or in combination with low-dose corticosteroid therapy. There is a role for biological therapy such as infliximab or cyclosporine in patients with resistant disease, but if ineffective, surgery should not be delayed. Severe fulminating disease is a medical emergency and requires treatment with intravenous fluids and steroids. If this fails to induce remission, cyclosporine may be used. Colectomy with ileostomy or ileorectal pouch is undertaken for severe fulminating disease, which may be complicated by a toxic megacolon, or for chronic poorly controlled disease. There is increased incidence of adenocarcinoma in the colon in adults 1 in 200 risk for each year of disease between 10 to 20 years from diagnosis. Regular colonoscopic screening is performed after 10 years from diagnosis. Constipation. Constipation is an extremely common reason for consultation in children. Parents may use the term to describe decreased frequency of defecation, the degree of hardness of the stool, or painful defecation. The normal frequency of defecation is highly variable and varies with age. Infants have an average of 4 stools per day in the first week of life, but this falls to an average of 2 per day by 1 year of age. Breastfed infants may not pass stools for several days and may be entirely healthy. After 1 year of age, most children have a daily bowel action. A pragmatic definition of constipation is the infrequent passage of dry, hardened feces, often accompanied by straining or pain and bleeding associated with hard stools. There may be abdominal pain, which waxes and wanes with passage of stool or overflow soiling. The constipation may have been precipitated by dehydration or reduced fluid intake or an anal fissure causing pain. In older children, it may relate to problems with toilet training, refusal, and anxieties about opening bowels at school or unfamiliar toilets. Examination usually reveals a well child whose growth is normal, the abdomen is soft, and any abdominal distension is normal for age. The back and perianal area are normal in appearance and position. A small fecal mass may sometimes be palpable in the lower abdomen, but is not necessary for the diagnosis. A primary underlying cause for constipation is rare, but a number of underlying conditions should be considered. Hirschsprung's disease, lower spinal cord problems, anorectal abnormalities, hypothyroidism, celiac disease, and hypercalcemia. Red flag symptoms and signs indicative of more significant pathology are detailed in box 14.4. Digital rectal examination should not be performed. It may sometimes be considered by a pediatric specialist to help identify anatomical abnormalities or Hirschsprung's disease. Investigations are not usually required to diagnose idiopathic constipation, but are carried out as indicated by history or clinical findings. Constipation arising acutely in young children, for example, after an acute febrile illness, usually resolves spontaneously or with the use of maintenance laxative therapy and extra fluids. In more long-standing complication, the rectum becomes overdistended with a subsequent loss of feeling the need to defecate. Involuntary soiling may occur as contractions of the full rectum inhibit the internal sphincter, leading to overflow. Management of these children is likely to be more difficult and protracted and often requires a multidisciplinary approach. Children of school age are frequently teased as a result of secondary behavioral problems are common. It should be explained to the child and parents that the soiling is involuntary and that recovery of normal rectal size and sensation can be achieved but may take a long time. The initial aim is to evacuate the overloaded rectum completely. This can generally be achieved using a disinfection regimen of stool softeners, initially with a macrogol laxative, for example, polyethylene glycol, uh, polyethylene glycol, electrolytes, plus electrolytes. An escalating dose regimen is administered over 1 to 2 weeks or until infection resolves. If this proves unsuccessful, a stimulant laxative, for example senna or sodium picosulfate, may also be required. If the polyethylene glycol plus electrolytes is not tolerated, an osmotic laxative, for example lactulose, can be substituted. This infection must be followed by maintenance treatment to ensure ongoing regular pain-free defecation. Polyethylene glycol, with or without a stimulant laxative, is generally the treatment of choice. The dose should be gradually reduced over a period of months in response to improvement in stool consistency and frequency. Dietary interventions alone are of little or no benefit in managing constipation in this situation, although the child should receive sufficient fluid and balanced diet. The addition of extra fiber refer to the diet is not helpful and may make stools larger and more difficult to pass. The child should be encouraged to sit on the toilet after meal times to utilize the physiological gastrocolic reflex and improve the likelihood of success. The outcome is more likely to be successful if the child is engaged in the treatment process. This requires exploring the child's concerns and motivation to change. Sometimes use of behavioral interventions, for example, a star chart, is helpful to record and reward progress, as well as to motivate the child. Encouragement by family and healthcare professionals is essential as relapse is common and psychological support is sometimes required. The mainstay of treatment is the early, aggressive, and prolonged use of laxative medication in a dose that allows the passage of large soft stool at least once a day. One needs to emphasize that the use of laxatives is safe, even long term, as underuse is the commonest reason for treatment failure. Occasionally, the fecal retention is so severe that evacuation is only possible using enemas or by manual evacuation under an anesthetic. They should only be performed under specialist supervision, paying particular attention to avoiding distress and embarrassment for the child. Hirschsprung disease, the absence of ganglion cells from the mesenteric and submucosal plexus of part of the large bowel results in narrow contracted segment. The abnormal bowel extends from the rectum for a variable distance proximately, ending in a normal innervated dilated proximal the dilated colon. In 75% of cases, the lesion is confined to the rectal sigmoid, but in 10%, the entire colon is involved. Presentation is usually in the neonatal period with intestinal obstruction, heralded by failure to pass meconium within the first 24 hours of life. Abdominal distension and later bowel stain vomiting develop. Rectal examination may reveal a narrowed segment and withdrawal of the examining finger often releases a gush of liquid stools and flatters. Temporary improvement of the obstruction following the dilatation caused by the rectal examination can lead to a delay in diagnosis. Occasionally, infants present with severe, life-threatening Hirschsprung enterocolitis during the first few weeks of life. In later childhood, presentation is with chronic constipation, usually profound, associated with abdominal distension, but usually without soiling. Growth failure may also present. Diagnosis is made by demonstrating the absence of ganglion cells, together with the presence of large acetylcholinesterase positive nerve trunks on a suction rectal biopsy. Anorectal manometry or barium studies may be useful in giving the surgeon an idea of the length of the aganglionic segment, but are unreliable for diagnostic purposes. Management is surgical and usually involves an initial colostomy followed by anastomizing normal innervated bowel to the anus. Summary of Hirschsprung disease: absence of mesenteric plexus of rectum and variable distance of colon. Presentation usually intestinal obstruction in the newborn period following delay in passing meconium. In later childhood, profound chronic constipation, abdominal distension, and growth failure. Diagnosis: suction rectal biopsy. And that's the end of the chapter.